very good about picking these up. The gestational diabetics, those who have any of the hypertensive disorders of pregnancy, and then preterm birth. But when you look at the bottom, there's so many things there which we have to really draw into the picture. They are non-gender specific. So in the same way as they affect men, they will affect women. One thing that I want to stress because of the angle I'm taking is the social determinants of health, SDOH. And of course, what I just spent time talking about, the sleep, disordered breathing. Let's think about all of that. And of course, poor nutrition. This case I presented, for instance, I wonder how well she is nourished, let alone now that she's pregnant. This is one of those guidelines that we all like to quote, that show up on exams, and we know. And this is a modified WHO risk stratification for those women who have congenital heart disease. Now, we know this so well. And then if you are WHO class 4 in the bottom in red there, you know, all of us, you know, talk about, maybe pregnancy is not recommended. Let's tell them not to get pregnant. I always jump on a soapbox to say, before you tell a woman not to get pregnant, please make sure she has a fail-proof contraceptive, method. As you're talking to her, somebody's ready to take her into the next room, give her all the pros and cons of whatever we have out there, and please, 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 IUD, cheap copper IUD. And then when she's all set, you can decide whether she's in a classification that can even think about pregnancy, because you cannot have that discussion, don't get pregnant, when we're not helping them not to get pregnant. This is another variation of the WHO classifications, and we're very good about knowing which is a very high risk, and therefore, you know, if I take WHO class 4, for instance, people who have severe pulmonary hypertension, severe mitral stenosis, they've had PPCM in the past, they have a low ejection fraction. We're very good about telling them this is a very high pregnancy. In fact, don't even get pregnant. And if they are, we tell them all these scary things. And then they have to deliver at an expert center. We're checking them monthly, and they go to this expert center to deliver. What screening tools do we have available to help us with this? And what I'm about to say is that we have some screening tools, but from where we sit, you know, in limited resource areas and different parts of the world, some of these screening tools are wonderful, highly academic, but are they really helping us get these risk factors taken care of? For instance, what I'm showing you is the CARPREG-2. All the red arrows are showing they predict the adverse cardiac events in pregnant women with heart disease, and the blue arrow actually lists some variables that estimate pregnancy risk. Some of those variables impact, you know, specific individuals. I'm not going to go through it because I'll share my slides at the end, but I'm sure we've all seen this before. This slide is just to remind me to say that we did have CARPREG-1, which was Canadian-based, population Canada. We did have CARPREG-2, the same wonderful cardiologists who work very closely with pregnant women developed the CARPREG-2, which is what I just showed you, actually. Very, very helpful. It can give you all the risk factors and all that. Then we have Zahara, which came from a Dutch population. Okay, so where I'm going with this is when we sit in an African setting, or even here in the US, if you have a low resource setting, you have the Latinas, you have the African Americans and all that. Many times, some of these things don't quite gel with our constitution, so to speak. Wonderful tools, you know them for exams, but how are they really helping us take care of these patients? So if you took those screening tools, all the maternal risks for these cardiovascular diseases, please, please, please remember they were developed among populations in high-income countries. You do still need a multidisciplinary discussion. You know, what risk factors does a woman have that are not heart-related? Any adverse obstetrical outcomes, adverse fetal outcomes, you do, you know, all of that are included. But we really have to pay attention to the ones I haven't read at the bottom of the slide. You know, the logistics of care, accessibility to anything basic or specialized care that this woman would need. For example, how far is it between where she lives and that specialist center you want to send her to get her follow-up care monthly, as well as, you know, deliver there because she's WHO modified class 4? What are the psychosocial disadvantages? This scenario I presented, there are so many in there. Language barriers, sometimes as simple as you speak one language that many people in that region can speak, but that particular one may not speak it. So these are not in the screening tools. Okay, so you see where I'm coming from, that, we have a lot of work to do. It's been published that maybe what we should do is to look for any high-risk cardiac condition, list them. The ones that we already know for exams, like the Marfan's and the congenitals and the bicuspid aortopathy, and people who have very severe aortic stenosis, mitral stenosis, maybe due to rheumatic heart disease, those who have low ejection fraction, less than 30%, and on and on. Those who already have coronary artery disease or even a dissection, the Eisenmengers, all these are high risk. Maybe we should take those. Knowing that, should we ask ourselves, does this woman have a high risk lesion or not? Yes or no? If they do, they're high risk. If they don't, you could use a CarPreg too, plus the lesion they have, to consider whether they're in intermediate risk versus low risk, and then help them. Another suggestion, which is the latest, recently published, is how about we use what we learned in medical school? Physical exam, taking a good history. Physical exam, taking a good history. So if that's what we're going to do, we have all our multidisciplinary people as healthcare providers, as part of this woman's care. Our whole goal is to have a universal screening tool that we can use anywhere. Everyone who's gone to med school, you know how to take a good history and then do a good exam. So on your history taking, you can address a lot of the risk factors that I had in that scenario, ask how she's even eating, where does she sleep, and all those things. So you have all of those. Does she drink alcohol? Is she smoking? And then this shortness of breath she's presenting, take a good history of that, as well as list everything she's telling you in her own lay terms, and then try to see what it is in the equivalent of medical terms. Physical exam, what we're trying to do is to look for any loud murmur. Does she have crackles in her lungs? Like, I'm worried about this woman having heart failure, for instance. What is making her so short of breath? Does she have water in her lungs, or she has sounds that are because she's wheezing because of lung parenchymal disease? And then, of course, the vital signs. In terms of vital signs, anyone can take vital signs and put them on the chart as soon as she hits healthcare, and then we can be following. And then after all that, because we're talking low resource settings should be able to use this too, you get into a little quandary here. Many places can do EKG, many cannot do echo as fast as they need to, or as quickly as they need to. And then when it comes to BNP, troponins, and all these other lab tests, some places can draw them, but you may not get the results right away. And some places it's a send-out test. So those may or may not help, but that's in the universal screening. And if we had to put our money where it would make more bang for us, it would be great to develop a place that would give us these tests. When we have those, and then we have a good referral pathway that we can send these women through to the point where they actually get to the right counseling that they need to modify their risks or to take care of whatever disease they already have on board, that would help. So this is a very recent one. The same thing I said has been put into this algorithm, and because of time, I wouldn't go through. Like I said, I'll share my slides, but all of that is leading towards being able to take a very good history, do a very good physical exam, and know which ones have the high risks. And by doing this, the benefits will be both immediate, short-term as well as long-term. And we're worried about heart disease. So what can we treat now? What can we treat, later on? And then what are we preventing from happening in the long term? And this slide is just to tell me that I'm done. And if there are any questions, we can talk about now.
Thank you so much, Prof. Aqua, for that very insightful overview of cardiovascular disease. I think we see a lot of this in our setting, mainly driven by rheumatic heart disease. And most of these have had some replacement. And unfortunately, because of our care at primary care level, and sometimes patients coming from far, and hence our issue about access. that patients may not have been counseled properly and therefore not put on a proper method of contraception. I liked your statement that we should go straight for copper IUCD and negotiate later in terms of the appropriate methods. Yes, and thank you so much. You did well also introducing yourself. So basically, thanks. While we wait, and I'm not seeing any, there is time for questions. I'm not seeing any hands at this moment. Anyone in the audience? Yeah. So basically, this is, I just want to welcome everyone while we wait. And just to introduce this as our first webinar on Women's Health Series. And I want to appreciate our international speakers that have agreed. Prof. Tita and Prof. Aqua are both on the other side of the continent and therefore very early in the morning. Thanks for taking the time. Prof. Tita has joined us, and while I think questions are still coming or comments, I do not see anything on the platform. I will ask that we move on to his talk. I do want to request Prof. Aqua, if you would be able to hang around to the end, maybe there will be some discussions at the end. Is that all right?
Okay.
Okay, thank you. Thank you so much. While Prof. Konje, we will take him last, but for now we will allow Prof. Tita, who is Director of Mary Helsink Institute of Global Health at the same institute in Alabama, the University of Alabama at Birmingham. He is the Mary Helsink Endowed Chair of Global Health and also on women's health. I think he would do a better job than me trying to read. So he's been very much involved with global research. And you will remember that at some point he visited with us here at UKZN. And it gives me a great pleasure to invite Prof. Tita to speak to us on advances in management of preeclampsia, also a very common condition that we see. And both this and the previous talk, we will know that are amongst our top 5 causes of maternal mortality. Ayanda, if you may just allow Prof. Titas to be able to host and share his slides, and over to you, Prof.
Yeah, thank you so much. It's a pleasure to be here. I appreciate the invitation. In my day job here, I work as a high-risk obstetrician, and I'm just going to labor and delivery after this, where I'm sure we'll have a number of preeclampsia patients. So just to set this up, can you see my slides in the proper view format?
Yes, we can. Thanks.
Okay. All right. So, you know, I'm sorry, the first talk with amazing talk by Professor Aqua went before mine, because the natural sequence is mine, and then the risk of preeclampsia and the association with long-term cardiovascular adverse outcomes, you know, follows. But I am going to talk about preeclampsia, and you know, the topic and title of advances in management of preeclampsia gives me a lot of some discomfort, because the question comes in, what are the advances, right? Things are moving relatively slowly, despite a lot of ongoing effort to bring about innovation in this area. So what I decided to do was just a great overview, well, a good overview of preeclampsia, what the definition is for those who may be at earlier levels, and then touch on some of the more recent advances. So let's see. Yeah, so as Professor Aqua did mention, hypertension in pregnancy can you know, have multiple presentations, as chronic hypertension pre-existing, gestational hypertension when it's new onset hypertension in pregnancy, And then the main concerns of preeclampsia, which can include subcomponents of eclampsia and HELP, and then the worst case scenario where preeclampsia superimposes on chronic hypertension with a lot of adverse outcomes. I also want to point attention to the fact that what we actually use to as the primary method to determine preeclampsia, which is blood pressure measurement, has a lot of issues, right? There is wide variability in BP measurement from, between observers, within observers, between instruments. And so this brings about some confusion in the management. And so efforts are being made to have some standardization, which, I summarize here in terms of, do you do some of these things when you measure blood pressure in order to have a more accurate measurement? Do you provide some rest? Pay attention to just simple things, size of the curve, having the arm at heart level, and then repeating the measures and doing an average or taking a more recent measure. And then what type of a BP device, do you use? Are you using an auscultatory method as opposed to an oscillometric method, which is more frequently used? And the thing is, the oscillometric methods tend to go with some level of underestimation of the blood pressure. But the most important thing, I think, is consistency in what you do, and especially the device you use, so that measurements can show a trend. Also, a quick reminder about some of the basic physiologic changes that occur in relation to blood pressure during pregnancy. So we know there is up to a 50% increase in cardiac output as the blood volume increases by 50%. There is also a 30% increase in red cell mass, and the 30 versus 50 leads to some relative hemodilution. But most importantly, blood pressure drops, some would say between 12 to 18 weeks, so in that early mid-trimester, and then rises again back to baseline by 28 weeks. Historically, this nadir has been put to be at 18 weeks, but we have done some, and others have done some more recent studies that would suggest that that nadir may actually occur somewhere around 24 weeks or so, and then maybe earlier in those who are destined to have hypertension or to have preeclampsia. And it's a hormonal effect, and renal vasodilatation is an underlying mechanism. So this is an old, a figure that depicts this and saying that on average, adjusted for age, those who are having a baby for the first time tend to have higher blood pressures than those who had a prior pregnancy, again, adjusted for age. And some of that speaks to nulliparity being a risk factor for preeclampsia. And this also depicts some of that where the nadir lies, but it's now more, later in that window, and that poses major implications and confusion and a diagnostic dilemma with respect to how we diagnose superimposed preeclampsia. And I will come back to that. So this just, summarizes again preeclampsia as a multi-organ dysfunction, primarily based on blood pressures being above 140, 90. There are ongoing conversations about whether they should be taken down to 130, 80 or greater, but it remains 140, 90 or greater. And this needs to be demonstrated at least twice in a reasonable time apart, 4 hours, and obviously after 20 weeks. Now, the diagnosis could be made at 18 weeks, depending on what the particular picture and underlying circumstances are, but generally 20 weeks and above, plus any one of all these things, including proteinuria measured in various ways. Some would argue about the dipstick, whether it should be 1 or 2, but 2 is associated with fewer false positives, so most places will go with 2. But if that's all what you got, and there are other findings suggesting preeclampsia, then even 1+ reinforces that finding. And then you look at all of these other markers here that can occur in association with blood pressure, and even in the absence of proteinuria would lead to a diagnosis of preeclampsia. And I'll come back to some of this. I think we're moving away from pathology, but glomerular endotheliosis has been sort of the standard hallmark for preeclampsia, shown here on the left, with damaged endothelial cells leading to partial closure of many of the capillary lumens, and you can see some of them here. This is a figure that is published in a recent New England Journal of Medicine review that walks us through the pathophysiology. And as we know, the pathophysiology of preeclampsia remains an enigma, and it's not exact, but we are learning, a lot more. But there are multiple things that can relate to reduced uteroplacental blood supply, or other things, especially molar pregnancy, that can lead to increased fetal-placental demands. And then you have questions around uteroplacental mismatch, sincere trophoblast, effects that may involve things like microvesicles, which are actively being investigated for their predictive effect and diagnostic effect for preeclampsia, as well as some of the more known ones around androgenic imbalance, S-fleet, decreased placental growth factor, and increased S-fleet. And then all of these, including a number of risk factors that we are going to talk about a little bit more, then lead to a confluence that's a maternal systemic endothelial dysregulation and inflammation that also leads to vasoconstriction and acute atherosis, and then brings about a multi-organ dysfunction that defines preeclampsia. Really interesting layout, but I think provides a great framework for how to bring about innovation in preeclampsia, and something I recommend to look at if you've not seen this. So preeclampsia, as we know, is categorized as severe or mild, and obviously severe, worrisome for eclampsia and other adverse outcomes, and is mainly characterized by now a higher blood pressure threshold of 160, 110, systolic, diastolic, or greater, and all the other factors that define preeclampsia except proteinuria. And again, low platelets, creatinine being elevated. There is some controversy around this doubling of the creatinine. I hardly ever use that in my own clinical practice. Elevated liver enzymes, pulmonary edema, persistent headache, which can be the main cause of falsely acting on preeclampsia. So really paying attention to that being persistent, and then also persistent visual symptoms. So the differential diagnosis, some of this outlined again by Professor Akua, chronic hypertension, gestational hypertension, kidney disease, acute liver of pregnancy, and other hormonal states that lead to elevated blood pressure, some of this induced by medications. And then briefly, the diagnosis again of superimposed preeclampsia in the setting of chronic hypertension can be a challenge and something one needs to pay attention to. I think the most important way of getting around this is to have information about blood pressure and proteinuria early in pregnancy or just preceding pregnancy, because then that can provide crucial information about whether some of these things are occurring newly or later in pregnancy. So what is new onset proteinuria in the setting of hypertension? What is considered an elevated level of blood pressure below baseline in someone who has chronic hypertension? People have defined this in various ways. Is it a 20/10 systolic diastolic? Is it a 5/10? I've used a 5/10 in some circumstances. And if someone is already had blood pressures well below early on in pregnancy, and then is having increasing requirements for medication, then that could also lead to that diagnosis. But you can see how a diagnosis of superimposed preeclampsia could easily be missed. So paying attention again to previous blood pressure and escalation of medications crucial. There are multiple risk factors for preeclampsia shown here, and some of these vary by the societies, but what I have there in orange pretty much depicts what we would consider as some of the more high risk factors for preeclampsia, and the ones we really want to target the most when we try to do interventions or want to conduct studies efficiently to get at how to control or prevent preeclampsia and have a high impact in terms of risk reduction. You can see them multiple factors. You can also look at nulliparity and then some of the rare things on the right hand of this panel. So moving on to antepartum management and some of the key principles, which we know is treat severe hypertension or treat hypertension, closely monitor the mother and the fetus, optimize the timing of delivery. What else is there to gain after 39 weeks in someone who has preeclampsia? And in fact, what else is there to gain after 37 weeks in someone who has a diagnosis of preeclampsia? And then the question around 39 weeks is whether, based on some of the oncoming studies around induction, more so in the US than in other places, where by delivering earlier rather than later, preeclampsia can also be prevented. I'm also paying attention when a diagnosis is made to preventing seizures, providing antenatal corticosteroids. Here we would do until just before 37 weeks based on the ALPS trial that we were part of. But I know many places will go through to 34 weeks and for corticosteroids, and then also continuing monitoring postpartum. Very important to treat, obviously, hypertension. There is the rapid treatment in the setting of severe hypertension using these medications shown here. More commonly here, we do labetalol and hydralazine, IV in the setting of severe blood pressures to get things under control, and then consider oral medications for maintenance. In many other places, I know nifedipine is a strong consideration, especially to minimize intravenous or parenteral use. And then for oral management as well, maintenance methyl-dopa remains, though has fallen relatively out of favor, remains a good option. And then you can see labetalol, nifedipine again, and methyl-dopa used in the setting of non-severe hypertension to continue to control blood pressures and potentially minimize the effects of superimposed hypertension. There is the question of, maternal and fetal monitoring during the antepartum period. Should this be done inpatient or outpatient? I think the jury is still out on this, and many places, for economic reasons, can consider outpatient management. But in settings where access to health facilities may be challenging, then inpatient or a nearby housing becomes more important. But monitoring blood pressures, especially because things can change suddenly, or weight, because things can also change suddenly there, and be a premonition for more severe preeclampsia. Monitor labs, ultrasounds for growth and fluid, and then also doing some antenatal testing intermittently. So intrapartum and postpartum management, seizure prophylaxis, very important with magnesium sulfate. And I think the dosing, whether it's parenteral, intramuscular, or intravenous, is known to many. We can go into those details if that's of interest. But paying attention to magnesium toxicity, the hallmark of which can be cardiorespiratory suppression, but early things around reflexes, reduced breathing, etc., can be early indicators. and then also managing that toxicity with calcium gluconate, very important. And this is something that should readily be available in all our units. Then delivery, what is the route of delivery? I think there are many who would, in some instances of severe preeclampsia, opt for a direct cesarean delivery, which also has its risks as major surgery. Here, we tend to keep cesarean delivery for the usual obstetric indications, and we've demonstrated that even doing an induction in as early as 28 to 32 weeks would carry at least a 50% chance of successfully delivering vaginally. Obviously, higher the later the gestational age. And then platelet transfusion, if doing a cesarean delivery, when platelets are below 50,000, and some would also argue if it's a vaginal delivery, then somewhere 10,000 or less may consider doing platelet transfusion, though that there's some controversy around that. Fluid balance is important, and to avoid pulmonary edema. And then also, as part of this, continued management in the postpartum period is providing counseling in terms of recurrence in future pregnancies, depending on the type, may be more likely to occur. And then also this risk of development of cardiovascular disease, which based on the subtype of hypertension may be somewhere between 1.5 and a 3-fold increase in risk of cardiovascular disease in the future. So moving on to prevention of preeclampsia, we know low-dose aspirin is a mainstay, especially in high-risk populations. So a modest reduction of maybe 10% in the risk of preeclampsia in those in general populations, with including moderate risk individuals. But when we focus on high-risk individuals, then the reduction may be as high as 50–60%. And so that's something to pay attention to. We are in the process of, because our population is so high risk that we are identifying, when we look at different criteria, up to an 80% categorization of high risk for preeclampsia. What we are doing now is working on universal aspirin for our population and planning an evaluation to look at the benefits, but also to look at just how important the risks might be. No heparin, not shown to be effective, except in instances of antiphospholipid antibody syndrome. Weight loss is effective in reducing preeclampsia occurrence. Exercise for an appropriate duration is also effective. And then doing some of the things that prevent iatrogenic increases in preeclampsia, avoiding multiple gestation in the settings of IVF, for example, and then considering a fetal reduction in the settings of higher order multiples would also have an effect on preeclampsia. And then more recently, out of our own work, we can discuss some more the pathophysiology, treatment of chronic hypertension. Patients with mild chronic hypertension were able to demonstrate a reduction in a number of outcomes, including preeclampsia. And that is the CHAP trial. And so just walking through some of the questions around prevention of preeclampsia, you can see this again from that review from 2022 in the New England Journal. Moderate exercise, 140 over 140 minutes per week cumulative can lead to up to a 40% reduction in preeclampsia, depending on the review sources. And then also for those at high risk, initiating aspirin before 16 weeks, our guidelines would say after 12 weeks, but there are increasing studies that would suggest that as soon as early as you can get them, better. And you can see up to a 60% reduction in preterm preeclampsia. And then calcium has been the other one that WHO has recommended for a long time, with up to a 50% reduction in preeclampsia in populations that may be under or have low calcium rates. There's just a more recent study published in the New England Journal where calcium 500 versus 1,000 compared, and the 500 was found to be non-inferior to the 1,000 as well. So thinking about those. And then we get back to this question of time birth, avoiding delivery after 39 weeks, or delivering, as soon as you get to 39 weeks is associated with a reduction. And we did show that in the ARRIVE trial that we did with inductions of labor in nulliparous women at 39 weeks versus expectant management to later. All right, so just as I end here, just a quick update about our own ongoing completed study on mild chronic hypertension. We are currently doing a bunch of other studies related to this, looking at long-term outcome for the mothers, long-term outcomes for the index infants, seeing them at 7 years since delivery. Was also doing a number of preeclampsia epigenetic studies from specimens collected during those pregnancies. And then in the process of doing genome-wide studies, metabolomics and proteinomics, just some complex studies that can help provide insights into the pathophysiology or pathogenesis of preeclampsia. So CHAP, as you may know, was an open-labeled study here in the US at over 70 centers, and involved NIH. Shown in red is just the coast-to-coast representation of states in the US in the CHAP trial. And the hypothesis was to evaluate whether antihypertensive therapy to a goal less than 140/90 for non-severe chronic hypertension during pregnancy will reduce adverse pregnancy outcomes associated with chronic hypertension without increasing SG, and these outcomes included preeclampsia. And so what we did was look at women with mild chronic hypertension whose blood pressures were generally below 160, 105 before 23 weeks, and randomizing them to an active arm where we treated them to a BP target less than 140/90 with labetalol or nifedipine as first-line treatments, or a standard arm where treatment was not given unless they had severe range blood pressures. And the primary composite outcome included preeclampsia with severe features, preterm birth before 35 weeks abruption, and perinatal death. We also looked at SGA, defined as 10th or 5th percentile, and this is sort of the flow, and ended up with 2,408 women at 61 sites, and followed them through 6 weeks postpartum, 97% complete. And this just shows how balanced the population was, with a high representation of minority populations here in terms of almost 50% were Black, non-Hispanic mothers. This just shows that there was a difference as soon as we randomized in systolic and diastolic blood pressure, modest difference with a lower blood pressure in the active arm in both for most of the pregnancy, until later on when those two lines then again became more approximate. So a modest effect on blood pressure did translate to also a modest benefit for the primary composite outcome that included preeclampsia, just on nearly a 20% reduction in that outcome in the active arm as compared to the standard arm, corresponding to having to treat 15 to prevent one of those outcomes. And this is an interesting survival analysis which showed that for most of the time after randomization, for approximately even 14 weeks or so, those groups continued to do well, similarly with respect to outcomes, even though they had a slight difference in blood pressures. And then later on, they then became separate with better outcomes for those who were in the active group, and the color code changed here. So blue is actually the active group doing better. And then, as you can see, preeclampsia with severe features there, approximately a 20% reduction in that primary composite as a component, and then also a reduction in the indicated preterm birth. The others not significant, but in the direction of benefit. No differences in small for gestational age, defined as 10th or 5th. And then again, any preeclampsia, regardless of severity, a similar amount of reduction here, 20% in favor of the active arm, and also a reduction in any severe hypertension in favor of the active arm, as expected. No differences in neonatal outcomes overall in terms of morbidity, but fewer preterm births and low birth weights in the active group. And I think in the interest of time, I'm going to end there, and thank you for listening, and I'm happy to take any questions. Thank you.
Thank you so much once again, Prof. Tita, for that overview and revision of the hypertension. And I think I appreciate greatly you sharing your the work that you are doing, and particularly on this last presentation on the CHEP study. So I see that your drugs of choice is labetalol and nifedipine, and very little or no mention of methyl dopa. So what would you say in a setting such as ours? We tend to start with that for all forms of hypertension in pregnancy, including preeclampsia. Do you anticipate that we would, so you showed the difference that there is a significant reduction in the disease. So do you anticipate that we would benefit the same, or should we just abandon the drug?
Great question, thank you. And this also sort of mirrors how things have changed since, I moved here. When I moved here, some 20 years ago, it was methyl dopa as the #1, the safest medication, in pregnancy. And then there was this concern that, it may not be as effective in reducing blood pressure as nifedipine or as labetalol. There was also some concern that methyl dopa may have this side effect of causing some sedation. And so just, like that, and really based on more anecdotal information or evidence than real evidence, in the US, things started shifting. At some point, there is not methyl dopa is not the first line anymore. There are 3 first lines, all 3, right? And then subsequently, the 2 first lines are labetalol and nifedipine. Now, if you go back and look at the information carefully, methyl dopa is an effective antihypertensive medication. All these medications do have some side effects. Nifedipine has issues with headache, and it's more likely, when we did with this trial, we're more likely to see patients switch from nifedipine to labetalol because of side effects than the other way around. There is a great 3-arm trial done by CBI where methyl dopa, labetalol, nifedipine were all evaluated, and they all brought about reductions in blood pressure. So the short answer to your question with that background is that yes, in a setting where methyl dopa is what is available and patients take their medication, I would expect that the benefits of reducing blood pressure or treating hypertension would accrue. So I consider methyl dopa as an effective blood pressure medication.
Yeah, I think indeed we see that. We start with that, we get effective reduction in our blood pressure. And as well, we haven't had much of those side effects. It could be that we are not looking hard enough or maybe interacting, but so far we haven't really had any experience with having to stop it for any of its side effects. If anything, we actually just continue to add second line or third line as is necessary.
Absolutely.
And thanks once again. I wanted to, yes, you were saying?
No, I was just going to say absolutely, and that was my experience as well, right, in my own patients, but given the collective community experience of people thinking that the other two probably brought the blood pressure down, faster, everyone and organizations started to move with policy implications. But I think you're in a good place with methyl dopa, especially when you start considering things like costs.
Exactly, yes.
Can you hear me?
Yes, Prof. Konye, please go.
Yeah, I just want to ask Alan and probably yourself. So in the UK, if we use the methyl dopa antenatally, we tend to switch it within 48 hours of delivery because of the risk of postnatal depression. I don't know whether you want to comment, you care to comment on that, and whether it's the same experience in South Africa.
Yeah, I can go ahead, and that has not been and was not a concern here. The issue with methyl dopa and having to consider switching to other medications, had to do with what were the first-line medications outside of pregnancy. And I think that's the other concern too with the with some of the changes. So people would tend to do nifedipine, long-acting, or amlodipine, calcium channel blockers, because the evidence outside of pregnancy would consider those as first line. But postnatal depression wasn't one of those that was acutely in our view as a concern. But we almost do not use methyl dopa anymore.
Okay. Thank you.
Thank you.
Yeah, and in our setting, we do switch as well within 48 hours. Not so much post depression, but much more maybe postural hypertension and other side effects. To the extent that actually most of our patients who persist to where the blood pressure doesn't remit after delivery, they hardly ever go home on methyl dopa. They are usually on an ACE inhibitor or HCT, hydrochlorothiazide. Yeah, so we do switch as well. Yeah.
Okay, thank you.
I was going to ask Prof. Tita if there is any category of patients where without severe features who you would consider to deliver before 30. Maybe like a prima gravida, you get to 37 weeks and you deliver, or do you? And this is not with severe features that you would say you would deliver before 39 weeks.
Oh, yeah, just to be clear, we deliver at 37 weeks when there is a diagnosis of preeclampsia. Clearly, diagnosis of preeclampsia, if it's severe, we deliver at 34 weeks, looking at what resources are available for newborns on balance. We think delivering, on balance is fine for the newborns and reduces side effects for moms. But at 37 weeks, we deliver, and the question is whether to deliver earlier, say, looking at some of the HIPITAT studies where 36 weeks was timing of delivery. We can consider additional risk factors, twins, other considerations to deliver, say, at 36 weeks. The question around 39 weeks is just in general for the population delivering around 39 weeks. But I can understand what you're getting at. There are some patients who are maybe at high risk for preeclampsia, but do not have preeclampsia that we would consider delivering earlier. Some of this may be patients who have things like prior SGA, other things that may have been suggestive of underlying preeclampsia, and a combination of factors. We could make an argument to consider delivering between 37 and 39 weeks, and especially between 38 and 39 weeks. But in general, early delivery in the absence of preeclampsia tends to occur at 39 weeks, and any preeclampsia 37 weeks or earlier.
Yeah, I think we follow similar in that regard. So with that, thank you so much once again for your time. You did indicate that you will be rushing to the labor room. And if you are able to, you can hang around, but otherwise, thank you so much. we appreciate your time. I do not see any other hands up. So we will then move on to Prof. Konje, and thank you so much for once again also agreeing to be part of this. So Prof. Konje is very familiar to most people who've been around in South Africa. He's visited us several times, graced a number of our local conferences. He is an emeritus professor of ONG at the University of Lancaster in the UK, and also right now at Qatar University as a senior consultant in fetal maternal medicine. He's agreed kindly to do a gynae topic for us. And just to mention that he's also been very kind to agree to be an honorary appointment in our university. So he holds that position now. And yeah, so this is home ground for you. Thanks, and over to you, Prof. Konje. Thank you.
Thank you very much. And I hope Alan is still there. So Alan and I come from Cameroon. So I have heard of him and read his work. So it's actually quite nice to relate to him and actually hear him speak today. So it's been really nice to meet you.
Yeah,
so
I was thinking exactly the same. Thank you.
Absolutely. So I will, okay, can you all see my screen?
Not yet, bro.
Okay, let me share. Okay. Can you see it now? Oops.
Yes.
You can see my screen.
It says agree to whatever
I've actually
version.
gone back to, this is not my screen.
We can see your screen. It's not yet on slide share.
Yeah.
Okay.
It's not on slide share.
Now, perfect. Thank you.
Is it on slide share?
It was. Now you've gone back, Prof. Not
Is
yet.
that okay?
Yes.
Okay.
Perfect now.
Okay, great.
Thank you.
Well, thank you very much for having me. Yes, you're absolutely right. South Africa is my home, and I'm very fond of South Africa. I'll be talking on endometriosis. Although I'm fetal medicine, I actually spend a lot of time working on endometriosis. So I hope that I'll try and make my talk as hopefully clinically useful to those people who are listening. So this is a cartoon by a patient of mine. And this is a young girl here who is at home with her father. And the father is saying, oh, another one of those days, because her mother's had a very severe pain before, and the family doesn't understand. And then this is what this young girl's pelvis looks like. And when we did a laparoscopy, we found this very severe endometriosis. So what is endometriosis? It is really a condition where viable endometrial tissue is found outside the uterine cavity. It's one of the most common causes of pelvic pain in women of the reproductive age group. And this here is just a cartoon of the endometriosis. This slide should have come first, so I apologize for that. What I'm intending to cover today would be looking at a background covering prevalence, pathogenesis, the types of endometriosis and staging, looking at the clinical features, diagnosis, management, and then looking at endometriosis and cancer. How common is endometriosis? Well, it affects about 1 in 10 women in the reproductive age group, and this will give us about 170 million women affected by endometriosis worldwide. It is a very common cause of chronic pelvic pain, responsible for about 50 to 60% of cases, dysmenorrhea in 80% of cases, and infertility in 30 to 50% of cases. Interestingly, endometriosis also affects menopausal women. So when I was a medical student, I was told that it doesn't affect women after menopause, but we now know that it does affect menopausal women. Where does it occur mostly? Most of it is either on the ovaries, in the posterior cul-de-sac, or the pelvic side walls. However, it can affect the ureters, the pelvic organs in general, and it can also affect virtually every part of the body. We've had endometriosis in the brain, in the chest, but interestingly, it's never been reported in the spleen. Why do women have endometriosis? Well, the exact reason is unknown. And so endometriosis is often regarded as a disease of theories. And I'm just going to go through some of those theories. The first one was proposed by Robert Mayer in 1924. This is a coelomic metaplastic theory, essentially saying that normal peritoneum undergoes metaplasia and then becomes endometrial tissue. That will explain the location of endometriosis within the abdominal cavity in different sites. Now, Sampson in 1925 proposed the retrograde menstruation, which has become the most popular of these theories, and I'm going to come back to this. And then we have the blood and lymphatic spread, which has to explain why endometriosis can go to the brain and to the chest, again, proposed by Sampson in 1927. And more recently, we have the genetic propensity proposed by Simpson in the US and the Muskie in the US about abnormal immunity. And of course, there are now environmental factors that increase the risk of endometriosis, including dioxins, which are present in PCBs that we use for foods storage, and progesterone resistance being one of those factors. If we look at retrograde menstruation, we know that it occurs in 90% of women, but 90% of women don't have endometriosis. So why is it that a certain proportion, a small proportion, 10% will develop endometriosis? It's primarily because of the processes that are involved in removing the viable endometrial tissue that is present in menstruum. And these processes are cellular adhesion and proliferation, somatic mutations, inflammation, localized steroidogenesis, and immune dysregulation. So in those women who would develop endometriosis, these processes are abnormal. And this slide, which I borrowed from Professor Linda Kudis, who wrote a review in 2020, demonstrates what happens with retrograde menstruation. So the menstruum flows back, is deposited in the peritoneum. Then you have all these processes that are involved in either removing that viable endometrial tissue or encouraging it to implant and grow. What are the risk factors for endometriosis? The first one is atypical menstrual patterns, and I'm going to come back to this. Low birth weight, this is now beginning to emerge, that low birth weight is a risk factor. Mullerian abnormalities, these are the ones that will cause obstruction to menstrual outflow. Low body mass index, nulliparity, genetics. And I've put race here with a question mark in social class. In the past, it was said that endometriosis was a disease of the higher socioeconomic class. My feeling, and I think most people believe that too, is that those were the people that were more likely to be diagnosed than those who were in the low socioeconomic class. But there are some dietary factors that may increase the risk in people who are in the high socioeconomic class. So what are these atypical menstrual patterns that I've spoken about? Early menstruation. So the girl starts menstruating before the age of 12. Her periods are regular, more than irregular. So those who have irregular periods are less likely to develop endometriosis. The interval between periods is much shorter. We're looking at less than 27 days here. Those that have severe cramps have a 4 times greater risk of having endometriosis. And those whose periods last longer than a week have a 2.5 times greater risk of having endometriosis. But then we spoke about the genetics of endometriosis. What is it about genetics of endometriosis? What we know, and I'm not going to go into the genes that are involved, is that if your mother or sister have endometriosis, then your risk of developing endometriosis is 7 to 8 times greater. What is even more striking is that for this familial type, it tends to be more aggressive But sadly, it's diagnosed at an advanced stage, primarily because people will say, the mother will say, I had pain with my periods, therefore it is expected. And there's a delay in making that diagnosis. And this illustration, which was published this year by Professor Cadiz as well, is just demonstrating the life course of endometriosis, from genetic susceptibility to fetal development that results in low birth weight, and then the early menarche and the menstrual problems, all of them combining to increase the risk of endometriosis. What are your typical symptoms? Severe dysmenorrhea, deep dyspnea, chronic pelvic pain. And I will come back to this because the chronic pelvic pain in most cases is typically cyclical, but centralization, which I'm going to come back later, can make the pain constant and exaggerated. And that's where we tend to overlook the symptom as being linked to endometriosis. Dyschezia, which could be cyclical in most cases, where the woman feels as if she wants to empty her bowel, but she can't empty it. Infertility, of course, bloating, fatigue and depression, and other cyclical symptoms. And I'm going to come back to fatigue and depression because this can be linked to central sensitization. So what is central sensitization? Well, it is a process in which the central nervous system undergoes structural, functional, and chemical changes that make it more sensitive to pain than other sensory stimuli. So the patient who's got endometriosis is more likely to have this central nervous system changes, making her pain much more great, and sometimes making the pain vary from cyclical to constant. So chronic pain or other symptoms for these patients seem to be out of proportion to any identifiable pathology. So the patient comes with very severe pains, you examine her, and you don't find any pathology that will explain that pain. Well, central sensitization is thought to be due to a reduction in descending modulation of peripheral signals, the so-called gator theory, or cross-sensitization giving rise to symptoms in visceral and somatic structures. So the patient has got endometriosis, but she's got bowel symptoms. She's got backache. She's got severe headaches. She becomes depressed. And these are all linked to this central sensitization. And this was recognized by I think it's I've got to try and remember how to pronounce it. It's NIH in the United States as an entity in, I think, 2015, where it says it accounts for the evolution of cyclical to non-cyclical chronic pain, and it exists with under conditions, the cluster of conditions together called referred to as the chronic overlapping pain conditions. And this may be endometriosis coexisting with vulvodynia, irritable bowel syndrome, and painful bladder syndrome. Or the patients may have chronic migraine, chronic low backache, myalgia, chronic fatigue syndrome, which is really what I see in a lot of my patients, and fibromyalgia. So if a patient has got all those symptoms, we must think of the differentials. And I put the 3 key differentials here because those are the most important symptoms of endometriosis. With dysmenorrhea, you must think of adenomyosis, uterine fibroids, primary dysmenorrhea, or obstructions to the lower genital tract. With deep dyspnea, you have pelvic masses, myofascial pain, painful bladder syndrome, irritable bowel syndrome, and I state here that it coexists in 40% of cases with endometriosis and pelvic inflammatory disease and pelvic congestion syndrome. And with chronic pelvic pain, you have all of these syndromes here, which can coexist with chronic pelvic pain in patients with endometriosis. So how do we make a diagnosis of endometriosis? Well, there are no biomarkers, no blood test, and there is no reliable diagnostic test for endometriosis. That means, as clinicians, we must have a high index of suspicion and depend on our clinical judgment. Previously, you had to visualize, i.e. do a laparoscopy, take a biopsy for it to be confirmed histologically. And in fact, they will argue that there are some patients who have symptoms, no obvious disease, and you take a biopsy of the pelvis and histology would confirm that they indeed have endometriosis. So currently, the recognized and recommended approach is to base your clinical diagnosis on symptoms with or without ultrasound scan. And surgery should not be used as a diagnostic tool for endometriosis. And I'm going to come back to that. Imaging, ultrasound scan or MRI, there are limitations. And surgery as a third option, usually in patients that treatment has failed. Why is this approach being proposed now, i.e. clinical rather than surgery? Because surgery is not curative. Most of the time you do the surgery, or what you do is you will just see the disease, and then you will treat. And what is even more important for changing this approach is that it delays the diagnosis. So the patients are referred, and I'm talking about in the UK, for example, they wait for a long time to have a laparoscopy before they have surgery. So why is there a delay in diagnosis? For various reasons. These are just 4 typical examples. The symptoms vary. They're not recognized by the healthcare providers and families. And there has been a stigma around discussing endometriosis, although this is beginning to change. And there's a very important paper that was published in 2023 in the BJOG by Elise Ricard. And I just want to make reference to this paper. They looked at 63 countries in the world to figure out just how long it takes to make a diagnosis of endometriosis. And you can see that from these 63 countries, the delay was 9.6 years. It took 3.7 years between the first symptom and physician contact, 5 to 8 years from the first physician contact to diagnosis. And this was worse with the older women. For the younger women, less than 35 years, it was 6.8 years. And for the older ones, was more than 10.7 years. And the conclusion from that from this study was that it takes long for healthcare providers and sufferers to recognize that endometriosis indeed is responsible for their symptoms. But what is actually, to me, what was really worrying was what was found from the perception of the physicians. These are just examples. This is what it's like to be a woman. Everyone gets cramps. I was told pain is a woman's lot in life. Physicians said that my pain was all in my head. You are faking it for attention. You are too young to have endometriosis. My symptoms were blamed for me putting on weight. All of this, and this I was quite familiar with in the patients that I saw in my clinic. But equally important was this finding, that if you look at those that were aged 18 to 24, 82% of them had their symptoms dismissed by physicians. That number dropped to 77% for those aged 25 to 34, and then 35 and above by 73%. But look at the sexism that was exhibited by the physicians towards these patients. This red here are the male physicians, the blue are the female physicians, and the purple are both. And only a minority of physicians were not sexist to their patients, to the younger patients. Most of the physicians were indeed sexist in their comments. So what are the consequences of delaying diagnosis? Well, the disease progresses, becomes more severe. The patient develops more severe symptoms. It becomes more complex and expensive treatments in the States and other parts of the world. They lose time at work and family time, and impacts relationships and their marriages that break down because of this. And of course, there are many, many additional doctors' visits which are not free. And of course, they do have multiple diagnostic tests for other conditions. So what is the effect of delayed diagnosis? There was a study that was done in the UK. We did this study in the UK, looked at 1,955 women. And what the study showed was that it causes emotional distress in 83% of patients. 69% had doubted themselves. 61% had a very low esteem. 90% were depressed. And 60% had marital problems. Their marriages were breaking down because of delay in diagnosing endometriosis. So what are the benefits of early diagnosis? Well, the patients are relieved, and I'm just going to show you an example. A patient told me that now I can get on with my life knowing that it is not in my head, because all along she's been told that it's in her head. They're able to seek appropriate treatment, and of course, less time lost from work, and they restore self-confidence and self-esteem. And this is just a paper in 2008 from a colleague in the UK, just looking at how reliable the clinical signs of endometriosis are in making a diagnosis. And you can see that the odds ratio is very high for dysmenorrhea, and subfertility. In terms of imaging, ultrasound scan cannot reliably diagnose superficial endometriosis, and the same applies to MRI. However, ultrasound scan is useful because it will identify endometriomas or deep endometriosis. And MRI will also help to pick up adenomyosis and deep endometriosis. Surgery is only indicated if empirical treatment has failed, or you want to combine surgery and the diagnosis. That's when you can do surgery. And this very busy slide is just a summary of how we manage the patients. So you have your classical symptoms here, you have the signs here, you have the risk factors here. You put all of this together, then you clinically suspect endometriosis. If you have a vaginal ultrasound scan, that is useful because it helps you to exclude endometriomas and deep endometriosis and other pelvic pathologies. But if you don't, you start the patient on treatment. First, hormonal treatment. Then if she does not improve on symptoms, then you might consider surgery. What are these? Just to talk about the progression of endometriosis, 2 studies have been performed on the progression of endometriosis that I'm aware of in the UK. One was by Chris Sutton, and they did a laparoscopy on patients who had endometriosis, and then did a laparoscopy again at 12 months. And what they found was that progress in up to 45% of cases, remain unchanged in up to 42, and then regress in 29% of cases. What are the types of endometriosis? Superficial, ovarian, and deep endometriosis. So here we have superficial endometriosis, and endometrioma, and deep endometriosis. This is your classical appearance of superficial endometriosis. This is superficial endometriosis with adhesions. You've got terrible adhesions from a superficial disease. You got deep disease here. This is infiltrating right into the bladder. You've got disease that is penetrating right into the vagina in this patient. These are all my patients. And then look at this patient's abdomen. This is a very angry abdomen. And not surprisingly, she had very severe pain. And of course, look at this patient's ovaries are completely buried. There's no way, and there's a uterus there. She will obviously struggle to become pregnant. And in terms of stages, the 2 tests or the 2 stages that we use are the revised American Fertility Society staging, which talks about minimal, mild, moderate, and severe, and then the endometriosis fertility index, which is used at surgery in those that are requiring fertility. The most important thing here is that there is no relationship between the stage of disease and the symptoms. I know I'm running a bit late, so I'm going to try and accelerate. So this is the classical picture that we use for the reversed American Society staging of endometriosis. And this is the one that the endometriosis fertility index is used at the time of surgery for those that have endometriosis. How do we manage endometriosis? Well, the patient should be managed in endometriosis center if you have one. In my unit, we have an endometriosis center. The patient is at the center of what we do. And you can look at the input from all these people. So I am just one. I'm just a physician. And then there are multiple experts that are involved in the care of these patients. And this is the evolution of the medical management of endometriosis from 1960 up to where we are today. You can see that the progression from oral progestogens. I just want to cite the Mirena, because that is my work. So we were very, very fortunate to have done the first study on the Mirena to show that it is, in fact, very, very effective in endometriosis. And we've currently been working on endocannabinoids, which are natural cannabis. And again, this is an emerging field which is going to become very useful in the management of endometriosis and other conditions. The European Society, the American Society, the Canadian Society all have guidelines. I'm from Europe, so I'm more likely to be making reference to the European guidelines. But most of the guidelines are the same. They say the same thing. So the first line management is to imitate pregnancy. And you should start without subjecting the patient to a laparoscopy. So a young woman, you start with a combined oral contraceptive pill. You can give it as an oral, give it as a patch, or a vaginal. In my clinical practice, I give it without the pill-free interval. So to take it for 6 months continuously. You can also give them progestogens, either as tablets or the Mirena or subdermal implants. Minimum of 6 months. Please be aware of the side effects: weight gain, irregular bleeding, and breakthrough bleeding. Then if they don't work, you go for the GnRH agonist. Now we're beginning to move away from the agonist to the antagonist. Why? Because when you give the GnRH agonist, what they do is they tend to cause very hyperestrogenization in the first 1 month. So the symptoms become very, very severe before the symptoms start abating. Whereas if you go with the antagonist, then that hyperestrogenization the first 4 to 6 weeks doesn't happen. And nowadays we have a combination of the GnRH antagonist plus estrogen and progestogen, and this has been shown to be extremely effective. So this, in my view, if I want now to go for a second line option, it will be this GnRH antagonist with estrogen and progesterone as an option. And you can now use this for up to 2, 3, 4 years. Whereas with this, once you've gone past 6 months, you run the risk of demineralizing that patient. So you have to be extremely careful. The third line options, the aromatase inhibitors, I use them only for the patients that have endometriosis that is resistant. So I've tried all the other things and they haven't worked. And I'll just show you a paper we published on this. We have testosterone derivatives. Again, this work in some people. And as I said before, cannabis and cannabinoids are becoming very important. And we published this paper just looking at our work. We had a series of patients that failed to respond to every other medication. But when we used the aromatase inhibitors, they responded to this. But of course, they come with their own problems because you are completely inhibiting the production of estrogens in these patients. And I'm not going to spend time going through this because it just summarizes the mechanism of actions for the various options. And just to say that complementary therapies have been shown to be effective in some patients with endometriosis. And I'm just going to then go on to the last series of my slides. Surgical intervention is when the patient's pain has been unresolved despite treatment, it's incapacitating, or you suspect disease is advanced, or she presents with an emergency, i.e. she's ruptured an endometrioma, or she's have bowel obstruction, or she's got obstructive uropathy. And surgery, superficial disease, deep disease, endometrioma. For the superficial disease, we just excise or you burn. It improves fertility. For the deep disease, it's radical excision. You may have to resect bowel and reanastomose. A hysterectomy is not a treatment for endometriosis. If you have to do a hysterectomy, it's best to combine it with ballotasap and go for rectomy. However, look at the recurrence risk after surgery. 22% after 2 years, and 40 to 50% after 5 years. And these are the kind of disease we're talking about, the deep disease that you have to excise surgically. And this patient here had endometriosis on her diaphragm. If you've taken out the patient's ovaries because she has endometriosis, what should you do? You should start HRT as soon as possible. Now, they used to say, give it a 3 months break or 3 months washout. I think it's criminal to convert a 35-year-old woman who is got normally functioning ovaries to a postmenopausal woman without that transition. So there is no evidence that delaying starting HRT improves or affects the outcome. And you can give the Mirena for 18 to 24 months after surgery because that would delay a recurrence of the endometriosis. What of endometriomas? Well, should we treat them, and how should we treat them? You should treat them if the patient has got pain, if they're ruptured, or you're worrying about malignancy. And the treatment options, the only one that is recognized and recommended is ovarian cystectomy. The other ones I don't use, and there's no evidence that they are indeed quite useful. And just to say that if the woman is trying for a baby and she has an endometrioma that is asymptomatic, you should not take out the endometrioma. There is no evidence that it improves a reproductive outcome. But ovarian cystectomy does reduce the ovarian reserve of these patients. And this is what I'm just saying in this series of slides here. So I'm just going to skip these ones. And just look at this conclusion here. The current evidence suggests that ovarian cystectomy does not improve reproductive outcomes of women with endometrioma undergoing ART. But ovarian reserves are affected by endometriomas. Now, my last few slides are just going to talk about endometriosis and cancer. There is a recognition now that women who have endometriosis have a doubled risk of ovarian cancer. And this, you can see the reference here, published in 2021, and I'm going to show you more data. The 3 types of cancers are clear cell carcinoma, endometrial carcinoma, and low-grade serous carcinomas. In the past, these were only linked to endometriomas, but the recent evidence is suggesting that these cancers are linked to all types of ovarian cancers. And here we have a paper published from database in the United States in 2024, just a few weeks ago, actually, in JAMA. You can see that the relative risk of these cancers is very high in patients with endometriosis, irrespective of whether they have endometriomas or deep infiltrating endometriosis. The same applies for this deep infiltrating endometriosis. So endometriosis as a whole increases the risk of cancer. And my last slide is just to say that if a woman has endometriosis and she becomes menopausal, in some of them, the disease continues to progress because the endometriosis itself produces estrogens. And in these patients, the treatment is either surgery or aromatase inhibitors. Every other medical option that you have will not work in these patients. So just to conclude, endometriosis is an enigma. It's a difficult condition to manage, but what we should be doing now is to try and reduce that long delay between the onset of symptoms and diagnosis by instituting treatment early and not waiting for surgery to make a diagnosis, because that way we will significantly improve outcome for these patients. That's where I'll stop. Thank you very much.
Thank you indeed, Prof. Konje. What a very concise and very broad overview throughout the whole topic, actually, and really from the beginning to the end. Thank you so much. And it's been very enlightening as well to see some of the work that you have done as well. I'm not sure if there are any comments from anyone in the audience. I do not see any hands. Siva, I'm sure you were going to raise your hand. You are more than welcome. Please go ahead. Prof. Konje would be happy to hear from you.
Thanks, Professor Konje, for excellent presentation.
Yeah.
In the last few years, we had about 4 cases of patients presenting with endometriosis in the lung, catamenial hemoptysis. And one of them recently was presented with pneumothorax, damage to the terminal bronchioles, pleural effusion, and she presented with recurrent ascites. She had a right-sided endometrioma, and she had spread through the diaphragm into the right side of the lung, and it fitted the diagnosis of thoracic endometriosis syndrome. And of the 5 patients that presented, this patient demised because she had recurrent. The problem was she was having recurrent ascites, and we put in a permanent, semi-permanent drain, and every day there was a drainage of at least about 750 to 900 mils of fluid. Now, we couldn't put our hands on what was causing this, and we presume that's from the sensitivity of the peritoneum that you have mentioned. But how would you be treating these sort of patients with thoracic endometriosis syndrome?
Thank you very much, Siva. It's really nice to hear from you. Interesting that you've talked about that patient. So we had a patient who had she was operated on by the thoracic surgeons in Leicester, and then what they thought was a tumor. They took it out and sent it for histology, and it came back as endometriosis. That's how I got to know about the patient. What you've described, the patient you've described, is a management enigma. Actually, I don't. Whether if you gave the patient, because there's pathology somewhere that is causing the recurrent ascites. Your endometriosis doesn't typically cause ascites, but it may be this a reaction to the endometriotic tissue that is causing the ascites. And I don't know whether if you gave her the GnRH antagonist, whether it would have made any difference at all, because I suspect that what was ending up producing the ascites wasn't the endometriosis itself, but was as a consequence of prolonged endometriosis that she's had. That's what I think. And that was what's caused pleural effusion and the pathology. I just don't know how you manage that, whether you would try and sclerose was it a pleural effusion, right?
Pleural effusion with pneumothorax and damage to the terminal bronchioles and damage to lung tissue.
I think that would be. Yeah, carry on.
Eventually demised of respiratory failure. She went into respiratory failure.
Yeah, that is really, really difficult. I would struggle to just see how you can manage that patient individually, which is why I say you need to bring a lot of people together, and even that, it remains an enigma. We don't even know how to deal with those sort of patients. Yeah, but that's a very interesting case. Yeah.
Thank you, sir.
Thanks, Siva, for that question. Thanks, Prof. Konje. I again do not see any hands. Unless there's anyone with a question. And on that note, I don't have anything on my side. Just remaining for me to really take this opportunity to thank all our speakers, Prof. Tita, he might have already left, Prof. Aqua, and Prof. Konje, for your time. We know that you have taken time out of your busy schedules and to be with us. We really appreciate the support and looking forward to more collaborations, more meetings if possible, and definitely when you are in the country.
Thank you very much.
I'll be very happy to welcome you.
Thank you very much, and it's been a pleasure. Letitia, thank you very much for your talk. I was going to ask, are you from Ghana originally?
Yes, I was born in Ghana, yes.
I had a feeling, okay. Well, I guess that
I
right.
also
Yeah.
wanted to add,
Oh,
I was waiting
all
for
right.
questions, but then I think going off the information I gave, a very simple, straightforward next step would be to include in your charting system either a form or some kind of a page if you're using electronic system where simple questions could be placed as well as simple physical exam points could be placed where anyone who's a healthcare provider can complete whenever they meet any patient, because it helps when down the line you as an OBGYN sees that page to start putting two and two together to suspect this is a woman that we need to suspect for heart disease. But it has to be the responsibility of everyone who this woman hits at the door of any healthcare setting. So it works well if you have some kind of a form or a sheet at the very beginning of the chart or something on your electronic medical system to do. And this is not high tech. It's just a way of addressing how we're missing these patients all through booking for antenatal care until they come in labor, when we could have caught them earlier.
Yeah. Yeah, I think, interrogating a woman each time she presents for care, as we know that with advancing gestation, the symptoms can be unmasked or exacerbated. So, yeah, I take that point of us going through that checklist of some sort at each interaction with the patient. Thank you so much. Is there anything else that we maybe, okay. On that note, thank you so much for the audience as well, for those who joined online, and to our speakers. We highly appreciate this, and have a good day and good afternoon to Prof. Bonje. Thank you.
Thank you.
Thanks, everyone.
Thank you.
Thank you. Thank you so much. Highly appreciate it. Thanks, Ayanda.
Thank you, Prof.
Okay, bye.